Assalamu alaikum. Our lecture now is about puerperium. We will have a review about the normal puerperial changes and some abnormal puerperium problem. Puerperium, it is the period just after birth. 6 subsequent post-delivery weeks during which normal pregnancy involution will occur. The clinical and physiological aspect of the puerperium would include changes about the uterine changes, urinary tract changes, relaxation of the vaginal outlet and prolapse of the uterus, peritoneum and abdominal wall, blood and fluid changes, breast changes and lactation, and few points about the care of the mother and the neonate in that period. Uterine changes. Regarding the changes in the uterine vessels, the caliber of the extrauterine vessels will decrease to equal size of the pre-pregnancy states, and this occurs after finishing the delivery. Blood vessels within the puerperal uterus obliterated by hyaline changes, replaced by small vessels. So there will be decrease in the size of the blood vessels of the uterine artery, and also the placental size will be decreased in its calibers. There are changes in the cervix and lower uterine segment. The cervical opening contracts slowly, and by the end of the first week it will narrow more and more, and as the opening is narrow, the cervix will become more thick and the canal of the cervix will reform again. The parous cervix or patulous cervix, it means that this cervix has a process of vaginal delivery, I mean dilatation and then retraction to its normal size. So the opening of this cervix would be patulous, transverse, and it will looks like fish mouth, while the cervix which did not passes in the process of dilatation and vaginal delivery will be like a pinpoint as shown in the picture. The involution of the uterine corpus, the fundus of the uterus will contract, and it will become at the level of just the umbilicus or just below it, and within 2 weeks this uterus would descend down into the pelvic cavity, and after 4 weeks it regained to its previous non-pregnant status. So if we want to palpate the uterus after the delivery, we can find the uterus is palpable between the umbilicus till the suprapubic ridge. After 2 weeks, it is not palpable abdominally, and then it will return to its normal non-pregnant status after 4 weeks. Regarding the weight of the uterus immediately postpartum, the uterine weight is about 1 kilo or 1000 gram. After 2 to 3 weeks, it returns to become 100 gram or less. The total number of muscle cells does not decrease or change, while the size of this cells is the decreased one. After pain, this pain usually experienced after delivery, the primiparous woman will have tonic uterine contraction, so she will experience a degree of pain in the pelvis and lower abdomen, mainly on the uterus, because it comes from the uterine contraction. In multiparous lady, this contraction will occur vigorously but intermittent. Especially this contraction will happen with the uterine, with the fetal or neonatal suckling. There is endogenous oxytocin release, which will cause contraction of the uterus, and so the woman will experience such pain. Occasionally, this pain is severe to need treatment or analgesia. Usually, it is mild and tolerable. The lochia. There is normal vaginal discharge, consists of blood, desquamated cell, vaginal and cervical secretion. Early in the puerperium, sloughing of the decidual tissue occurs, and this discharge with the vaginal discharge and cervical discharge all together form the lochia. First few days after delivery, there is blood in the lochia. 3 to 4 days, this blood will become progressively more pale in its color, pinkish, and then reaching to a yellow brownish in color. It continues for approximately 2 weeks after delivery. Sometimes some women experience this lochia, but of mild degree and low amount till the end of the puerperium. The placental site involution. Placental site normally consists of many thrombosed vessels within hours after delivery. So there is thrombosis of the blood vessel sinuses at the placental bed, and this is for sure, it's of benefit to decrease the risk of postpartum hemorrhage. Ultimately, it undergoes organization of this thrombus and a consequent sloughing of infarcted and necrotic superficial tissue, followed by reparative process. So repairing of the placental bed will occur within weeks after delivery. There is endometrial regeneration, and the remained decidua become differentiated into 2 layers within 2 to 3 days after delivery. The superficial layer, which becomes necrotic sloughed and passes through the lochia, and the basal layer. This layer will stay intact in the placental bed and endometrial cavity, and this is the source for the new endometrial formation. So it is responsible for the reparative process of the endometrium. The free surface of the uterus becomes covered by epithelium within a week or so. The entire endometrium is restored during the 3rd week after delivery. Okay. We mentioned when we talk in the previous slides about the normal involution. There is a problem which is called subinvolution. It is the arrest or retardation of the process which is normal, the involution. So involution is the normal process. Subinvolution, it is an abnormality in which the uterus after delivery will not return back to its normal pre-pregnancy status. The most common causes is retention of placental fragments or pelvic infection. It's usually accompanied by prolongation of the lochia discharge. Sometimes this discharge becomes bloody more and offensive, with irregular or excessive uterine bleeding, as we mentioned, and sometimes this bleeding may be in large amount that may cause postpartum hemorrhage. On bimanual examination, the uterus is larger and softer, plus minus maybe tender on palpation, than the normal one, and through the process or time of the puerperium. The treatment we will give methargine, ergonovine or methyl ergonovine maleate, oral antibiotics if there is signs of infection, or we call it metritis. The urinary tract changes in the puerperium. Normally the dilated renal pelvis and ureter return to non-pregnant status 2 to 8 weeks after delivery. There is a process of puerperial diuresis. That's to say, the women will experience much increase in the urinary output after the period of delivery, and usually occurs between the 2nd and 5th day, so diuresis are increased. Puerperial bladder, it will create optimal condition for the development of urinary tract. So puerperial bladder is a risk for urinary tract infection. This is due to increased capacity and relative insensitivity to the intravesical fluid pressure from the process of pain in the perineum, from the process of delivery, pressure effect of the descending fetal parts which occurs during the process of delivery, with perineal pain and sometimes injury to the paraurethral tissue. There is risk for overdistension of the bladder. which will result in sometimes incomplete emptying. And this incomplete emptying, because of the local pain in the perineum, sometimes associated with the episiotomy. Also, there is excessive residual urine in the urinary tract or urinary bladder, and this will increase the risk for infection and retention. Most women return to normal micturition by the third month post puerperium, and some of them will return to normal in the earlier period. Relaxation of the vaginal outlet and prolapse of the uterus. The vagina and vaginal outlet gradually diminish in size, but rarely it returns to the nulliparous dimensions. So there is some remnant changes in the perineum, and the perineum is not returned 100% to the pre-pregnancy or pre-delivery status. The hymen will be represented by several small skin tags. Also, the changes in the pelvic support during parturition will predispose to uterine prolapse and urinary stress incontinence, because there is some weakness and there is some injury in the innervation of the pelvic floor, so it will be weaker than non-delivered vaginally area. Operative correction is usually postponed until childbearing is ended because of risk of recurrence after delivery. Again, abdominal wall weakness usually return to normal and requires several weeks, and usually it needs an abdominal wall exercise to more strengthen the abdominal wall muscles. Usually it resumes its pre-pregnancy states except for silvery stria, we call it stria albicans. The blood and fluid changes. Cardiac output remain elevated for at least 48 hours postpartum. This is due to the increased stroke volume from the venous return after placental separation. The uterine contents and normal blood loss, we will have about 5 to 6 kilo decrease in the weight. Further decrease occurs during diuresis, about 2 to 3 kilogram. Till now we end the normal puerperal changes. We have complication of the puerperium. The most common and serious one is the puerperal pyrexia. What is puerperal pyrexia? It is a temperature of 38 centigrade or higher, occurs on the first 10 days post-delivery, with exclusion of the first 24 hours. That's to say, if the women experience high temperature after the first 24 hours after delivery, we should take it seriously and look for the cause. The most common causes for this puerperal pyrexia is puerperal sepsis, urinary tract infection, mastitis, wound infection, pulmonary infection. The puerperal infection or genital tract infection, it means any bacterial infection of the genital tract occurs after the delivery. It's about 6% in its incidence. It's one of the most important causes of maternal death. Now, it less occurred due to improved obstetrical care, availability of range of antibiotics. Risk factors for developing puerperal pyrexia could be happens from antepartum period. For example, women with malnutrition, preterm delivery, premature pre-labor rupture of membrane for more than 18 hours, pre-labor premature rupture of membrane, and HIV, diabetes mellitus. Intrapartum repeated vaginal examination, traumatic operative delivery, retained piece of a placenta, prolonged labor, postpartum hemorrhage, cesarean section, and manual removal of the placenta. All these are common causes for puerperal pyrexia or sepsis. The common pathogens includes aerobic, anaerobic, and others. Aerobic organism, for example, group AB and D. streptococci, E. coli, Klebsiella, Staph aureus, Streptococcus, Gardnerella vaginalis, anaerobic pepto and peptostreptococcal infection, bacteroids, and some other risk factors, microorganisms, for example, Chlamydia trachomatis or Mycoplasma. The clinical features and complications: the woman may have acute vulvitis, vaginitis, cervicitis, or may present with upper more infection, uterine infection, endometritis. Sometimes this infection extends up more to the adnexia, and sometimes having septic pelvic thrombophlebitis and septicemia. The diagnosis: on examination we will find high temperature more than 38 centigrade. The patient may have chills, sweating, tachycardia, offensive discharge, and bleeding. She may experience abdominal pain. On examination, the uterus is tender with subinvolution. The laboratory finding: we may find leukocytosis, increased YTBC, raised ESR, C-reactive protein is also raised. We should take high vaginal swab, cervical swab, and send for culture of the blood and general urine examination. The ultrasound examination may show retained piece of placenta, or it may find that pelvic abscess free fluid collection. Signs, symptoms: the woman may have headache, raised temperature, febrile, vomiting, dry tongues and lips. Abdominal examination will reveal suprapubic pain and tenderness with rigidity. The perineum, vulva, vagina, and cervix may become infected, and the lochia is offensive or foul smell. We should put a differential diagnosis for the puerperal pyrexia: any urinary tract infection, acute pyelonephritis, lower genital tract infection, wound infection, atelectasis, pneumonia, thrombophlebitis and DVT, mastitis, or maybe an appendicitis. The treatment: we should correct anemia and provide good hydration for the woman. If the woman has severe condition, we should admit her to hospital. Start antimicrobial treatment, gentamicin or clindamycin, or third generation cephalosporin and gentamicin plus metronidazole. We should think about a broad spectrum antibiotics. If there is an abscess by ultrasound or clinically, we should drain it. We should provide also a uterotonic drugs if we have vaginal bleeding. For example, we can give methergine or we can give oxytocin.